Hello, my name is Chen. I'm a former molecular genetics pathology fellow at Memorial Sloan Kettering Cancer Center. My co-presenter, Yi-Wei Tang, is the Chief of Clinical Microbiology Service at the Memorial Sloan Kettering Cancer Center. Welcome to this Pearl of Laboratory Medicine on HIV Serology Testing. The human immunodeficiency virus, HIV, is the etiologic agent of acquired immunodeficiency syndrome, AIDS. Worldwide, 34 million people are living with HIV infection and 1.7 million deaths due to AIDS in 2011. The CDC estimates that approximately 50,000 people are infected with HIV each year. Serology has been the mainstay for HIV infection diagnosis in the clinical laboratories. HIV is a member of the lentivirus subfamily of retroviridin. It is an enveloped virus that contains a capsid enclosing single-stranded RNA dimer. Replication of HIV proceeds with reverse transcription of genomic RNA into DNA intermediate, which is integrated into whole cell genome. HIV replicates in an error-prone manner that generates a mutation virtually every time it replicates. Major gene products of diagnostic significance for HIV-1 include amyloid proteins GP160, GP120, GP41, the capsid proteins P55, P24, P17, and polymerase gene proteins P66, P51, P31. The objectives for HIV serology testing are confirmation that an individual who has presented with signs or symptoms compatible with HIV infection is truly infected, and determination of the HIV status of an asymptomatic person who may have been exposed to HIV. Initial screening tests must be selected carefully, and if reactive, followed by confirmation assays to rule out false positive results and to verify true HIV infection. HIV screening tests include rapid tests and enzyme immunoassay EIA. The confirmation assays include multi-spot HIV-1, HIV-2 rapid tests in conjunction with fourth-generation EIA in the new HIV test algorithm, and Western blot assay and immunofluorescence assay in traditional algorithm. The two assays differentiate recent versus established infections. In contrast to conventional HIV enzyme immunoassays, which are associated with high rates of non-return for test results, rapid HIV antibody tests approved by FDA reduce unrecognized infection by improving access to testing in both clinical and non-clinical settings and increase the proportion of patients tested who learn their results. The tests are performed when immediate actions are needed in situations of perinatal and occupational exposure. Rapid HIV tests are simple to use with minimum equipment needed. The test can be performed by any healthcare worker with basic training. Test results are interpreted visually at the end of the reaction. Currently, 7 rapid HIV tests approved by the FDA are commercially available for use in the United States. These tests include OraQuick Advanced Rapid HIV 1-2 antibody test, Unigold recombinant HIV test, Review G3 Rapid HIV-1 antibody test, Multi-Spot HIV-1, HIV-2 rapid test, Clearview HIV-1-2 step pack, Clearview Complete HIV-1-2, and Instant HIV-1 antibody test. Only OraQuick Advanced Rapid HIV-1-2 antibody tests can be performed in home and over-the-counter settings. Our quick advanced rapid HIV 1-2 antibody test is one of the clear-wave rapid screening tests for use with fingerstick, venipuncture blood and plasma, and oral fluid. The kits are stored at room temperature. The device contains a natural cellular strip with synthetic GP41 peptides representing the HIV-1 envelope and the GP36 region of the HIV-2 envelope applied to the T-test location and a strip of gold anti-human IgG in the C-control location. Thus, the test screens for both HIV-1 and HIV-2. If HIV antibodies are present in the specimen, they bind to the peptides, causing a red line that appears in the test location. The red line in control location indicates a valid test result. Test results should be read no sooner than 20 minutes and no later than 40 minutes after the test device is inserted into the developer vial. Conventional enzyme immunoassay are initial screening tests. Most assays use purified antigen produced either from viral lysate or recombinant or synthetic peptides for detection of HIV-1 and HIV-2 antibodies. The average seroconversion or production of specific antibody to HIV is about 21 days. Thus, the antibody tests for HIV do not detect acute infection. Improvement of initial tests over time have led to the designation of test methods as first, second, third, and fourth generations. The first generation immunoassay use viral lysate antigens. The test is less sensitive and is associated with more false positive results. The third generation immunoassay use recombinant antigen and give less false positive results. The major improvement is the fourth generation immunoassays, which combine third generation antibody detection with HIV P24 antigen detection, allowing for detection of both antibodies and antigens simultaneously. In the new HIV diagnostic algorithm, reactive results from fourth generation immunoassay can be confirmed by multi-spot HIV-1, HIV-2 rapid tests, and no need of Western blot confirmation. Thus, the turnaround time is improved. The sensitivity of the third and fourth generation immunoassay is approximately 98 to 100%, with fourth generation being more sensitive than third generation. The specificity of the third and fourth generation is approximately 99.8%. Clinically, HIV infection progresses through stages from acute HIV infection to asymptomatic or latent phase, and finally full-fledged AIDS. The acute HIV infection is associated with high levels of viremia, generally resolves within a few weeks with the onset of a cellular and human immune response to HIV. The viremia declines from peak observed during acute infection and remains detectable over time with exception of rare population, long-term non-progressors, also known as elite controllers. Each stage has characteristic laboratory findings. Capsid protein P24, the most abundant viral protein, can be detected transiently within the first few weeks after infection. The disappearance of P24 antigen with seroconversion may be partially due to blocking of P24 detection by the formation of immune complex with anti-P24 antibody. Detection of anti-HIV antibodies is the mainstay of diagnosis of HIV infection. IgM antibody to HIV appears first and transient. IgM response is followed by a long-lived IgG response. The period of time from infection to antibody seroconversion, known as the pre-seroconversion window period, varies from person to person, but now depending on the assay. Detection of HIV antibody and seroconversion varies depending on the assay. The most sensitive fourth-generation combination assay are generally positive 4 to 7 days after detection of virus by nucleic acid testing. The third-generation enzyme immunoassay are generally positive 7 to 14 days after viral RNA is first detected. It takes longer 15 to 30 days for less sensitive first-generation immunoassay to become reactive, all for the development of a sufficient number of bands on Western blot to meet diagnostic criteria. The first-generation immunoassay was indirect EIA. These formats use coded viralized antigen on a solid phase for antibody capture and detected antibody using an anti-human IgG conjugate. The second-generation immunoassay used recombinant or synthetic peptide antigen to increase assay sensitivity and specificity. Both first and second-generation tests can only detect anti-HIV IgG antibody developed relatively late in infection. The third-generation assays were developed using antigen sandwich principle. The immobilized antigen captured HIV IgM and IgG antibodies in the patient's sample. The captured antibodies were detected through a second labeled HIV antigen and subsequent additional substrate. This allows for the detection of specific HIV IgM that occur early in infection, in addition to IgG antibody, which appears later. Thus, third-generation tests provided increased seroconversion sensitivity. The fourth-generation immunoassays incorporated HIV P24 antigen detection into third-generation antibody detection. The solid matrix was immobilized with both HIV antigen and P24 antibody for capturing HIV IgM and IgG antibodies and P24 antigen in the patient sample. The captured antibodies were detected through a second labeled HIV antigen and subsequently addition of substrate. The captured P24 antigen was detected through a second labeled anti-P24 antibody and subsequent addition of substrate. The introduction of P24 antigen detection allowed for the detection of acute HIV infection and provided the highest seroconversion sensitivity among 4 generations of EIA. Until recently, the Western blot assay has been historically referred as gold standard for HIV diagnosis and used in many algorithms for confirming HIV infection. Although highly specific, the assay requires time-consuming procedures and thus long turnaround time to report results. In brief, viralized antigen was separated by SDS page by their molecular weight, then transferred to natural cell membrane and blocked with protein-rich solution. This membrane was subsequently cut into strips and used as solid support for EIA testing for anti-HIV antibodies in patient specimens. The test may yield non-specific reactivity with non-viral proteins. The criterion for positive interpretation requires the presence of any 2 or more bands of P24, GP41, or GP120, GP160. Following the recommendations of the CDC and the Association of State and Territory Public Health Laboratory Directors, the test is interpreted as negative if no no band is present, and indeterminate if any bands are present, but the pattern does not meet the criteria for either positive or negative. Indeterminate Western blot occurs at the rate of 9% with P24 and 3% with GP 120-160 in HIV-negative patients. Risk factors are used to determine the frequency of testing and the likelihood of indeterminate Western blot pattern to represent HIV infection. Multi-spot HIV-1, HIV-2 rapid test is a moderate complexity assay approved by the FDA for use on fresh or frozen serum and plasma to both detect and distinguish HIV-1 from HIV-2. The test cartridge contains a membrane with microparticles immobilized in 4 spots. 2 spots consist of recombinant and synthetic GP41 peptides to detect HIV-1 antibodies. 1 consists of synthetic GP36 peptides to detect antibodies to HIV-2. And the 4th spot consists of gold anti-human IgG as the internal control. The test is considered positive for HIV-1 if the control spot and both of the HIV-1 spots turn purple. Indeterminate for HIV-1 if the control spot and one of the HIV-1 spots turn purple, and positive for HIV-2 if the control and HIV-2 spot appear. If purple appears in control spot, the HIV-2 spot, and one or both of HIV-1 spots, the test is considered HIV reactive and differentiated. In this case, the specimen may be tested by additional methods which allow differentiation between HIV-1 and HIV-2. The test is negative when only the control spot appears. The absence of control spot indicates an invalid result, regardless of any other spot pattern. The multi-spot test can be used as confirmation test for reactive results by 4th-generation EIA test in the new HIV test algorithm. Differentiating individuals with recent HIV infection from those infected for longer periods is important for establishing HIV incidence and for the purpose of clinical care and prevention. The discrimination is based on either antibody titer or antibody avidity using modification of current available EIA assay on serum-converted specimen. It has been mainly used for epidemiology purpose when paired serum specimens are not available. The sensitive-less sensitive serologic strategy, the serologic testing algorithm for recent HIV seroconversion stars, uses sensitive ELISA on original sample and less sensitive ELISA on diluted sample from the patient. The standardized optical density was calculated to estimate the probability of recent serum converters. The antibody avidity assay tests for the stability of antibody binding in the presence or absence of a caltropic reagent, guanidine hydrochloride. In avidity method, 2 aliquots of each sample are subjected to a pre-test 1 to 10 dilution in either 1 molar phasic buffered saline PBS or 1 molar guanidine hydrochloride and tested by immunoassay. The avidity index of HIV antibodies are calculated from the ratio of the 2 measurements, and avidity index less than cutoff indicates a recent infection. Lastly, an HIV test algorithm is a step-by-step testing plan to determine the presence or absence of HIV infection For patient screening or diagnosis, the traditional algorithm uses a conventional EIA or rapid test for HIV antibody followed by a more specific supplementary test, either Western blot, immunofluorescence assay, line immunoassay, or qualitative RNA test. Many initial assays are more sensitive during early cell conversion than the traditional supplementary assay, Western blot, and immunofluorescence assay, which produce an increased number of indeterminate or false negative supplementary tests. The new HIV diagnostic algorithm overcomes the above limitation. The new algorithm is designed to use a sensitive initial screening assay capable of detecting HIV-1 and HIV-2 infection during the acute, recency, and long-standing phases of infection. Optimally, an antigen antibody combination assay such as fourth-generation assay, specimens reactive by an initial screening assay should then be tested by an antibody immunoassay able to distinguish HIV-1 from HIV-2 infections, e.g., multi-spot HIV-1, HIV-2 rapid test. If the differentiation assay is also reactive, the presence of HIV-1 or HIV-2 antibodies has been established. If the differentiation assay is negative or inconclusive, further testing with nucleic acid testing should be performed to identify or rule out acute HIV infection. In conclusion, HIV is a caustic agent for AIDS. The HIV serology tests include initial screening tests followed by confirmation assay. The detuned assays can differentiate recent versus established infection. Thank you for joining me on this Pearl of Laboratory Medicine on HIV serology testing. I am Chen.